hoping that's worked. The red button's on, so that's good. Okay, I'm just going to give it to 25 too, if that's okay, just to let people join, and then we'll make a start. Morning, everybody. For those of you that are just joining, we're just waiting till 25 to just to give people a couple of minutes just to join, and if there are any Teams issues that we experience on a daily basis. I'll just let you know as well that I quite often experience Wi-Fi connection issues in Kirkland's. It's as if we've not paid the bill. So if I freeze, don't panic, I'll come back, okay? Just say that from the word go.
I'm dialing in from Kirkland's too, so I might go wonky at the same time as you,
Oh,
Christian.
okay, that's fine. We'll do that together. It's a bit temperamental, isn't it? Okay, what I'm going to do is I'm just going to get my slides up so that we're ready to start, because I know everybody's busy and we've only got an hour to do this. So let's just, that'll bring us right to bang on time. Now, hopefully people can see that. Just shout out and let me know if that's okay, because I'll not be able to see you.
Yep, all good.
Great, thank you. I'm just putting on to screen show it now. Right, okay. So I make that just coming up to 25 to, so I'm just going to make a start, and we've got a record on, so everybody will be able to pick up any of the bits that they might have missed. I'm really pleased to be here this morning as part of NHS Lanarkshire's Quality Week, just to give an overview on Operation Flow. I'm going to kind of break down the presentation into just a few stages. I want to first of all describe the approach that we took through Operation Flow 1, the impact that had on the impact of firebreak, what happened post firebreak, and our learning as a system, and what we'll be doing next through Operation Flow 2. I should say that if anybody has any questions throughout the presentation, I'm happy to take them as we go, but I'll not be able to see your hands coming up, so you would just need to shout out, or alternatively, it might be easier just to wait to the end. I'm happy either way, so if you've got a burning question, please just let me know. So obviously, NHS Lanarkshire, like a lot of the boards in Scotland, have experienced significant challenges in relation to urgent and unscheduled care. And as part of Operation Flow, we've wanted to undertake an assessment of our system and try and identify where some of our challenges were and what was causing our really difficult situation, both for staff and patients who were coming to our EDs and front door assessment areas. We knew we needed to undertake a kind of circuit breaker, and we called that a fire break. So we had to do something different to break that kind of cycle of really posting low performance levels against our target staff, reporting high levels of stress and distress. So we knew that we needed to do something different to break that kind of cycle, and that was why we called it the fire break, and that was about everybody coming together. And then the third stage around that is about how we develop a sustainable model. So the approach. So in preparation for what we needed to do, we started to work closely with colleagues across the whole system. It was a really, really collaborative approach. And we knew that we needed to prepare some of our for different ways of working. So we needed to create multi-agency discharge teams. We wanted to be able to enhance professional to professional pathways. I talked a bit about that collaboration. We really enhanced our collaboration with our Scottish Ambulance Service colleagues as well. We developed a targeted comms plan to explain what we were going to do, and we wanted to enhance our existing patient pathways to support admission avoidance and a home first discharge approach. We also recognised there was quite a bit of work we needed to do within our inpatient ward areas around how we develop processes and flow and monitoring. So, and also that we had kind of elements around how we would plan for discharge to support the busy teams in the inpatient areas. So we developed and implemented a flow foundation bundle. So there was a lot of preparation that went ahead of a fire break. It was about a 6-week lead-in time. The fire break itself was a whole system team approach, and that was to reduce avoidable attendance and admissions, and that was the kind of key objectives. The bit about how we improved ward efficiency, how we started to increase leadership and staffing. So we found that we brought in additional people at the weekends so that we had a true 7-day working. We had a lot more monitoring, and we wanted to ensure that our occupancy was around 95%. We knew that for our sustainable improvement element, we needed to evaluate the outcomes of the fire break. It was really important we learned about that. And we wanted to then work together to develop a new Lanarkshire model where we would have processes for monitoring and driving and sustaining that. And also we would help us to plan phase 2 of Operation Flow, which would shape the change that we needed going forward. So that gives you a bit of an outline of the overview of Operation Flow. The key objectives are to improve the 4-hour target performance. Whatever we might think of that, that is one of the key performance metrics that we are measured against as a board. But most importantly as well, reducing extended waits for patients in ED is key. We've got lots of patients waiting over 8 and 12 hours, and that's not a position that we want to be in. We knew we would be able to do that if we could reduce our occupancy and have a better balance of admission and discharges. If we could also reduce out of specialty patients, and I mean that by boarding, the term boarding, and a reduction in delayed discharges as well, and reduction in length of stay. So these were the objectives of the project itself and continue to be the underpinning objectives of Operation Flow 2. We had 3 key objectives for Firebreak. Just as I mentioned at the beginning, we needed to do something to decompress our whole system. We wanted to reduce ward occupancy levels to around 95%. And we wanted to take the acute sites out of full capacity plus. Those of you with clinical and operational roles within the organisation will know that across a number of the sites, there are additional patients in treatment rooms and bed bays as well. So we know that that isn't the way we want to deliver care going forward. And that would help if we were able to create that capacity to make sustainable whole system improvements to unscheduled care. People really need the space and time to be able to do that, and that's very difficult to do that when your system's running at capacity plus. So if you think back to the first slide I showed you around the preparation, this is some of the actions that emerged as part of Firebreak have emerged from that discussion that we had in terms of the preparation and the constant dialogue across the whole system. So we created MDT discharge support teams to look at every single patient across our acute and off-site beds, and we wanted to be able to identify and escalate clinically stable patients who were waiting diagnostics as well. And I guess MDT support teams is really around how we'd assess the criteria to decide for every patient in a bed across all our sites. We knew that there was a lot we could do with our flow navigation centre and increasing professional clinical decision making, particularly for care home residents, and also reducing the number of access routes for Scottish Ambulance Service to hospital-based urgent and emergency care. what we mean by that is that we wanted to implement a method that where there was patients that were perhaps borderline, so they weren't straightforward 999 needing to come to hospital, but there were maybe patients that were a bit in that grey area, that SAS crews had the facility to speak to a senior clinician to determine if there was an alternative pathway. We were keen to expand ambulatory care, so we looked at how we would be sending patients for that had minor injuries, and really it's probably more wounds than insect bites, etc., for referrals to treatment rooms to prevent them coming up to a hospital itself, and hospital at home to reduce. As part of admission avoidance, we wanted to increase their clinical capacity for 13 days. So Firebreak ran for 9 days, but we wanted to try and maximise that increased clinical capacity, so we didn't have to taper off during the Firebreak period, and that was about supporting more people in the community. We wanted to also increase capacity within home care teams for Wishaw and Cumbernauld, and that would provide increased support for discharge. And the full foundation bundle, which I mentioned at the beginning, which is around all the elements that are important for discharge, such as use of the discharge lounge, setting a PDD, criteria-led discharge, doing a criteria to reside assessment for every patient, and trying to ensure that patients are discharged where appropriate pre-noon to create early flow. So these were the kind of a key summary of the action. And what we were able to see was that actually, so Firebreak ran from the 23rd of February to the 3rd of March, and actually where we were as a system, we saw some really marked improvements. So prior to Firebreak, if you look at the first column, looking at the occupancy on the 6th of March, our occupancy across our sites was well over 100%, and actually as a system itself, we had a hospital occupancy of 105%. So we managed to achieve by the end of Firebreak an occupancy level of 94%, which was a really tremendous achievement for everybody involved. We also knew as well that actually before Firebreak, we were lucky if we were discharging 10% of our patients pre-noon, but at the end of Firebreak, we were actually able to discharge 25% of our patients. Still not massive numbers, but a massive improvement across the system. We also, where possible, tried to maximise the use of our discharge lounge, and we managed to increase that to 17% at the end of Firebreak. And again, that was in single figures from a percentage perspective before we started. The longest waits, although there were still lengthy waits during Firebreak and at the end of Firebreak, they were actually much less than they were previously. So patients were waiting up to over 24 hours in our A&Es. So to have a wait of 15 hours, 49 minutes was an improvement, although it still is an indicator that there was lots more that we needed to do as a system. Just a few more pieces of information to share with you in terms of the impact of Firebreak. So I talked a bit about the FNC and how we would support that redirection of patients to other parts of our system where appropriate. So during Firebreak, the FNC supported 4 key pathways. So that was they supported the extended opening times of hospital at home, so GPs could continue to refer to a hospital at home till later in the day. They managed the treatment room appointments, so that was around the patients that didn't necessarily need to come to ED for the wound treatments. They could go to the community treatment rooms. They managed that referral. And also they managed where there were residents from care homes that were to be assessed by a senior clinical decision maker prior to coming to a hospital. And they supported the senior decision making cover and consultant connect when there was nobody physically within the FNC as a senior clinical decision maker. So what we saw was that actually the total number of hospital at home referrals throughout Firebreak had increased. So up to 99, so almost like doubled, or actually doubled from the previous 7 days where they had only the 49 referrals. So that was a really good increase. The treatment room element was a bit of a slow uptake and not huge numbers, but definitely something that we might want to look at in the future. I think one of the most common presenting complaints were around animal bites, and there's only one pathway within Lanarkshire for patients who require a tetanus, and that requires AD attendance. Um, so we know on average 20 patients a week attend their local EDs for tetanus only, and there was 21 referrals requiring a tetanus, which they would have had to attend their local ED during fire break. So what we've agreed to do is scope with the vaccination team to determine if there's an alternative pathway that could be managed in the community for that particular cohort of patients. So we could increase that number of patients using that service. For the care home pathway, there was 10 referrals from care homes within NHSL, and we referred these patients over to the out of hours service after 6 o'clock, where a GP performs an assessment, and only one of the 10 required an admission. So that was a big difference as well, that the automatic default wasn't to bring patients up to ED. The FNC and the senior clinical decision cover, they diverted 96 NHS 24 patients away from ED by providing self-care advice or redirection to another service such as pharmacy or district nursing or back to the GP. So throughout the whole fire break period, the FNC directed 215 patients away from ED, and we would have been able to increase that to 232 if we had had access to a tetanus clinic or a different tetanus pathway. So that was a really good success story as part of Firebreak. The next few slides are just from the ambulance service, because obviously we worked really closely with them, and I'll arrange for these slides to be shared following so you can look at them in detail. But I guess in terms of the highlights, we saw that the numbers of emergency calls received within the Lanarkshire Health Board that's normal, just under the 2,000. The 42% of these were resolved without attending an acute hospital. So that means that 827 patients are treated away from hospital, and the ambulance crews treated 425 patients on the scene. What they did know also was that referrals to a hospital at home increased from an average of 5 per month to 17 during the firebreak period, and they also increased their use of Consultant Connect. So Consultant Connect provides professional advice electronically between different professional groups to help find alternatives to bringing people up to hospital. So the consultants and the hospital provide responses to either GPs or Scottish Ambulance colleagues. They also saw that they'd seen a decrease in average ambulance turnaround, something that we see a lot of in the media as well, and we were struggling with as well from a Lanarkshire perspective around that as well. There was obviously the exception of the old firm Sunday Monday, which always causes challenges across these hospitals that are affected by that. And this slide just shows an increase in the firebreak referrals to hospital at home, or the referrals during the firebreak period to hospital at home. We also saw referrals for supported discharge increased as well, and that also we saw an increase in that in the 3 days leading up to the firebreak, as we tried to create some space in the system. As part of another measure as well, if you see firebreak begins on the 23rd of February, we also managed to see a reduction in our delayed discharges during that period too. So that's all really good and really worthwhile celebrating. However, I think all of us on this call know that we've not been able to sustain these improvements. This slide just shows the Lanarkshire 4-hour access performance per day from the start of firebreak and up until the start of May, where we have been quite challenged to maintain the performance that we want. We've also started to see as well our occupancy levels shooting up again following firebreak, and the slide demonstrates that clearly in terms of where firebreak begins and firebreak ends. We've seen a reduction in occupancy to actually just below 90%, but actually we're way back up in the hundreds plus as well, so that makes things difficult. We also saw as well where we had a bit less variation, I think I would suggest, against our pre-noon and discharge lounge uses through the firebreak period. And again, we've gone back to increased variation around that. And also that is reflected as well in our variation in our unscheduled care performance as well. So it's important that actually we take learning from anything that we do and thinking about what we need to do as a system going forward. I think really, really importantly through the firebreak period that actually the staff reported that it was a fantastic whole system team effort. Everybody felt listened to and supported. And actually really key was that the staff reported that the sites are feeling safer. And it was actually much easier to identify deteriorating patients. I think where there were wards where there was lots of additional patients, that's been harder to maybe act on patients that are deteriorating as quick as we would want. And actually, firebreak allowed people to get back to that, which was really good. However, not all parts of the system reported that they felt the impact of decompression, and that was particularly apparent for I think some of the A&Es would report that took a bit longer to feel that impact of that decompression, and also other parts of the system that remain really busy, like primary care and community services, as well, felt no impact as well. They probably felt as if things were much busier for them too. We did undertake a report though of the learning, and this slide just demonstrates some of the kind of key points from that. So there was a lot of invaluable relationship building and understanding of roles and responsibilities. I think people really didn't always understand what happened in the community or primary care. They were just very focused on the bits of the system that they knew. So they learned a lot about some of what the community nursing teams could look after. And I think that was really important. We're really keen that we continue that so that we develop good flow going forward. As part of the Flow Foundation bundle, we used a SHOP structure. So SHOP stands for sick, and for S for sick, H for home, O for other, and P for plan. And that was a really key element that we implemented as part of the Flow Foundation bundle, so that every patient and every ward would have a board round review 3 times a day, so that we would be clear on why they were still in hospital and what were the actions needed to support them to get home. Because we all know that actually extended stays in hospital cause harm to patients as well. So that was really key and something that we've been really working on continuing. However, we also know within that actually discharge tasks are time consuming. So we need to find a way of supporting our workforce and discharge planning. I think we were keen to embed some of the principles of realistic medicine within operation flow, and we've started to talk about that as well. But really clearly we needed to revisit our ED assessment and ambulatory care processes.
Kirsty, sorry, can I come in and quickly ask about
you gave me a wee fright then, a wee flow. Carry on.
Sorry. I just wanted to ask about the realistic medicine part. So can you just expand on that a little bit about what the firebreak learning was specifically relating to medicine? Obviously, we're pharmacy teams, so that's relevant for us. I'm just interested as to a bit more specifics within that.
No, that's absolutely fine. I mean, I think probably, Kirsty, the key thing we thought about was actually this criteria to reside and actually understanding why we're keeping people in hospital and having some really frank conversations. So I think, we think about, we probably, there are circumstances where we overprescribe, we overdiagnose. So actually, could we start to embed some of the principles of realistic medicine within the discussions that we're having with patients and their families, as well as the wider team? So it was as broad as that. We didn't get into the detail of it, but it's a kind of ongoing conversation with the realistic medicine team. Does that make sense?
Yeah, thank you.
Okay. So we found that we needed to revisit ED and assessment and ambulatory care processes because actually, although we had created flow across our system, we were still struggling to process patients effectively within our front door areas. I realise there's a bit of a typo there, and apologies for that. I didn't clock that earlier, so I'll remove that before the slides are shared. But we need to ensure that we have real-time updating of track care for patient movements. So we've got a shared understanding of the status of our acute sites. What we've found is that actually we're batching some of our patient movements later in the day, so we actually don't have always a clear, accurate understanding of who's in our hospital at that time, which makes things very difficult as well when you're trying to measure impact too. We know, I talked a bit about the full foundation bundle, and we know that that's not all embedded yet, and that's a key piece of work going forward. There are multiple contact numbers in our communities services, and we need to review our coordination of urgent care responses in the community too to make that much more streamlined, so you're not having to undertake 4 phone calls to try and get hold of the right team. We need to do a bit of work around our confirmation of roles and responsibilities of the flow and discharge teams and have that once for Lanarkshire model. And we also need to think about the opportunity to streamline referral processes internally and off-site. So as part of Firebreak, I went along to a lot of the multi-agency team reviews, both through the week and at weekends. And what really struck me was that staff were having to remember processes for patients going to different off-site hospitals or off-site beds that were not the same. Times it would be a consultant referral. Sometimes they would take referrals from the ward doctor. Sometimes they would take referrals from the nurses. There had to be a written letter in some instances rather than an email. So that's a really difficult place to be. So we need to streamline that process. And also, I think the bit for me was actually we should be considering rehab at home rather than always off-site as well. That was some of the key learning. So we've taken all of this learning and pulled together a plan in terms of what we need to do for the next part of Operation Flow, which we're very simply calling Operation Flow 2. So, we're really really clear that we need to stabilise and improve our system up until summer of this year. And also, we need to think about the actions that are required to support the system through the winter period. We're really keen that we don't experience the same winter that we did last year and the impact that had on patients and our staff was really really traumatic in some instances. So we need to find a way that actually we do things differently to support our whole system. Any planning that we take out will require change and investment. Any change and investment that we put in place we will receive a lot of scrutiny. So we need to be prepared for that. So we've agreed that we need to establish task and finish groups to deliver our plan. We will also need to ensure we've got cohesive leadership and creating safe spaces to discuss where maybe we don't agree in some of the things. We need clear ownership by the operational teams. It can't be planning and development coming and doing it to people. We need to have clear, measurable objectives so we can see progress, but also we need to be agile if something's not working and being honest about that and maybe changing direction too. We need clearer responsibilities to develop and deliver our plan, and the pacing change we need to have before winter of this year. So the task and finish groups will support the delivery and implementation. So this slide, just to finish off, gives you an overview of what we've set up in terms of Operation Flow 2 task and finish group. So we've got established an executive flow oversight board, which we have to review the weekly plan and progress. And we also report, that group's overseen by CMT. There are 5 task and finish groups. Task and finish group 1 is that overview and core coordination, and that's chaired by Russell. And that also reviews the weekly actions plan, weekly performance review, and it ensures that the task and finish groups 2, 3, 4, and 5 are on track. It's required to produce a weekly report to the Executive Flow Oversight Board and also pull together the resource proposals as well. And we're also keen that we look at the flow management and on call during the out of hours period, because we know that's a time of vulnerability. The other 4 task and finish groups comprise of pre-hospital avoiding admission, and that is being chaired by Claire Ritchie, and that's looking at the FNC model development in terms of recognising the learning from Firebreak. What do we need as a model going forward, and what are the resource requirements for that? We also need to have that pre-hospital assessment. So that's around thinking about the use of hospital at home and how it supports admission avoidance, keeping and developing the consultant connect approach as well, and thinking about some of the community access pathways such as a discharge to assess, etc. So, and what we can do with the home assessment teams across the various sites. I know there's different names in the north and south. Task and finish group 3 is around front door redesign, planetshire. So that's a review of all our front door areas, and also thinking about what happens at the weekend, but creating a planetshire single model for both ED assessment areas and ambulatory care. And we're having a look at the resource review by shift and comparing where we were pre-pandemic to where we are now. Task and finish group 4 is around board and system flows. That's around how we have a consistent NHSL huddle across all of our sites, embedding the Flow Foundation bundle, and also thinking about how we escalate when actions are not taken or actions don't give us the results that we think they should. And we're also thinking about the resources required for our flow team. So that's around our bed management and discharge coordination and what that looks like in hours and out of hours as well. And then we've got a final group which today Marshall chairs, which is around frailty and off-site beds, and that's around the Lanarkshire frailty model across our whole system, but also including the front door frailty rapid assessment, but also what does the configuration of our off-site beds look like too going forward. You see also as well, we've got some of the objectives in the orange at the bottom, and also we've got a couple of other connected groups that are linking in. We've got a data and valuation group and a supporting people at home group too. So that just gives you a quick overview of Operation Flow and our learning from Firebreak and where we are now. And I'm just going to try and stop sharing my screen. Happy to take any questions. Casey.
Hi, thanks, Kirsty. That was a great presentation. Thank you. I'm really glad that I joined the session. Lots of learning. For me, I was really interested to kind of get more of the detail. A huge amount of work and loads of learning. And it's really helpful, I think, to understand, just to be clear, am I right in thinking that Operation Flow was about that kind of temporary, put in all of that resource and get that really rich learning? So there was never the intention that was going to be sustained. It was about getting that learning and then forming the plan, kind of going forward. Because I don't think everybody understands that. I think there's maybe a feeling like, oh, all that great work happened, and we can see that obviously the things are busy again. But it sounds like that was absolutely what you expected. That was the plan.
If I can be honest, Stacey, thanks for that. I think that's a really good question. I thought there would be elements we could have sustained. So actually, doing our board rounds where patients, we should be doing that anyway. We've been talking about that for 10 to 15 years. So I think there's elements within the Flow Foundation bundle like pre-noon discharge, use of the discharge lounge, and board rounds that we should have been able to continue. That should have just been business as usual, because these are not new elements. You know, we've been talking about this for a long time.
Yeah.
I think you're right, though. There was no way we were going to be able to continue with all the senior clinical decision makers providing support to the FNC in the way that we had. But on the flip side of that, I would have expected that actually we wouldn't have seen a reduction in our use of Consultant Connect or referrals to hospital at home from SAS colleagues. So we need to understand why some of that's not continued.
Yes.
But you're right, in terms of the additionality, and everybody, you know, worked crazy hours over the 9-day period, and lots of us had no breaks between over the weekend, etc. You can't sustain that. But I think there are elements that I would have expected we could have sustained. And I guess that's interesting to understand why some of the things that we thought were embedded and we've talked about for a long time across our system aren't.
Okay, thank you. That's really helpful. Just two other quick comments. So around about Consultant Connect, do we know, do we expect, is that fully rolled out? Is the expectation that that's currently available to all GPs? Because my experience, just personally, my experience is a GP practice saying, "No, we're not signed up to that. We don't use that." And it, you know, it seems to me like that's a great opportunity.
It is. So it's been one of these things that one of the ED consultants, Gordon McNeish at Monklands, has been probably single-handedly trying to roll it out and have the discussions. So what I've done is I've allocated one of the project managers from my team to support a greater rollout of consulting, because we can see that there are real benefits around that. And actually, it's probably one of the elements that it's just been a bit of a resource gap and a challenge for Gordon to roll out single-handedly. We always will find that some of the GPs will opt out, but I guess if we can get the majority of them using it, that would really help. And if SAS can use it regularly as well, I think that would be really, really beneficial. But we'll always find pockets where people don't want to use it or they've had a bad experience, etc. We want to increase the rollout of Consultant Connect, definitely.
Okay, just quickly, one other thing. I don't want to take up all the time, but just something that you said really stuck with me. It seems like a no-brainer, a key thing about that real-time update and track with patient movement. I was just really surprised to hear that that's not happening already, because if we've not got a current picture of the hospital position, then it must be really difficult to make the kind of real-time decisions. So presumably that's something that we're going to try and do quickly.
Yeah, so that's one of the key elements that we've been looking at in terms of is there a resource that we need to basically ensure that real-time updating of track happens? So, for example, could we look at an admin type role that could help support all the discharge planning tasks, and real-time updating of track would be one of them. So we've had a look at some of the other boards. For example, Tayside has basically 2 admin people that sit in their command centre and ensure that track is up to date. I'm not necessarily saying we're going to do that model, but we're looking at options around that, Stacey, because we recognise that's key, because not all the wards have ward clerks for all of the time. And they're also sometimes just early in the day and then they go home, you know, kind of early afternoon. So any other movements, often we find that maybe patients are being batched in the night shift, for example. So yes, the short answer is yes, we are.
Yeah, great. Thank you very much. Thank you.
Thank you. Kirsty, did you want to come in?
Yeah, I was just interested in how much this is a specific Lanarkshire, you know, designed and implemented, and how much, because I thought I'd heard things in other boards. I'm sure I heard the word firebreak, but I wasn't sure if it referred to something else. But how much if this was done in a similar way and across other areas, and if so, how much sort of linkage did you have, and did they have the same results?
So I think So fire break is a term that's been banded around quite a lot, and we're still using it where some of the sites are calling it a mini fire break. Actually, for me, the fire break that we did in Lanarkshire for the 9-day period was actually quite different. Everybody stopped what they were doing day to day to focus on actually how we would reduce occupancy across our sites, and they were working in a completely different way. We did look at some of the other models because Ayrshire and Arran had tried to do a fire break. I don't know if that's the board that you're referring to. They struggled to have such a big impact because I think they didn't maybe have all the preparation in place that we did for the fire break, if that makes sense. And that they came and have learned from us as well around that. So I get a bit probably anxious when I hear the term being called fire. We're still using the term fire break. We actually shouldn't really be saying that because it's not a mini fire break, because actually the fire break has to be as have such an impact as it did. So I think it's one of language actually that we've introduced a term and people are using it interchangeably, and actually it's quite different. I think when colleagues come from the HSCPs to support with hospital pressures, that's about an MDT working together. The fire break involved, diagnostics were all increased. They were all on gut. We're not doing that for the mini fire breaks. That's just been arranged at a site level. Does that answer your question? We did look at the other boards, but yeah, and the government asked us a lot about it as well, so we've been feeding into them.
And I suppose everybody will be looking at each other and picking the bits that work, and that's okay. So that what can we do differently?
Yeah.
I suppose refine over time. No, that's helpful. Thank you.
Yeah. Caroline, did you want to come in?
Hi, Kirsty. Yeah, thanks. I think that's been really helpful, your presentation. I'm involved, obviously, as we all are, in some of the work, but to hear it, from the kind of fire break period and the outcomes from that and the learning and how that's been shaped to get taken forward has been really, really helpful. So thanks for that. There's just a couple of things I was wanting to ask about. So one of the kind of things that struck me in one of your slides was around the number of 999 calls. So was it just under 2,000? Was that on a weekly basis?
Yeah, that was for it was a month, wasn't it? Let me just double check before I say something.
No, that's fine. I was interested in, I think it was, you had said 42.
No, but it was during the fire break period, yeah. Caroline, sorry.
Yeah, no, that's fine. So you'd mentioned that I think it was 42% of the patients treated were away from the hospital following a 999 call, had been redirected and treated away from the hospital. And I was just thinking about the kind of patient outcomes, particularly for those patients. Is there kind of data getting collected around that or looked at in terms of what happened to them, what ended up happening? Was that the right thing for them? Did they end up having to make a further 999 call later on and getting admitted to hospital, or looking at the patient outcome data? And one of the other things I was thinking about throughout your presentation, Kirsty, was kind of patient feedback and any kind of patient feedback around that period and what that looks like.
Yeah, no, thanks for these. The way they look at care opinion from a patient perspective, and there wasn't lots of comments specifically around the difference that people had felt. Some people had reported that it was great not to wait so long in A&E, which is good. We know we need to do a lot more in Operation Flow 2 around involving our public in this work. I guess the key objective of fire break was to try and decompress the system. So we did ask for the public's help to not come to ED if it wasn't required and let them know. But we also know that actually ongoing use of that message doesn't actually work. So we need to have a way of having a ongoing dialogue with our public around urgent and unscheduled care. So we are doing that a bit through the work we're doing around our new healthcare strategy at Our Health Together. But I'm really keen that actually when we think about our future phases of the work and through Operation Flow 2, that we actually have more public voices in the work and designing the models that we want to implement. I think we're very much learning, and I think what I would say is it does feel day to day as leading this work that actually we're building the plane as we're trying to fly it, if that makes sense. It does feel that we're constantly having to think again and change things and make some amendments and change timescales. So it's really, really fast paced. So if I was able to do this as head of planning and development with lots of time on my side, and I would be involving the public in a much more detailed way right from the very beginning. And I have said I think that is something that we are missing a trick, but we haven't done particularly well. We've just looked at what our current methods like care opinion and complaints, etc. In terms that it comes from the Scottish Ambulance Service, they do have that information. We haven't specifically looked at it. We did look as a, and I'm certainly happy to go and speak to SAS colleagues about that because I think that's an interesting point. We did look from a Lanarkshire system around our readmission levels to see actually if anything that we had done through Firebreak had an impact on readmission levels. And thankfully, we found that there wasn't an impact. We did know of a couple of cases through the Firebreak period where there was, particularly for a palliative care patient, where they'd made a decision that they wanted to go home to die. It was saying they were on an end of life pathway by this point, and actually, when they got home, I think for them and their family, it was really, really distressing. And actually, they ended up coming back to hospital. There was another story as well about another patient that had represented at ED for increased painkillers, but then refused to wait. So, but she was recorded as a representer. So we have tried to look at the detail of any of the patients that were in that period. There is a bit of a time lag with readmission, so we have to wait 28 days before we can see that data. But we are really mindful of that, and we will continue to look at readmission rates as part of the ongoing project so that we know that we're not having an impact from our part of the system. But in terms of the SAS data, I will definitely take that back to SAS, Caroline.
Okay, that's great. Thanks, Kirsty. Is
that okay?
Yeah, thank you.
Does anybody else have any questions? No? You get a wee 10-minute back that you didn't know you were going to get. It's always good, that, isn't it? Okay, listen, thanks very much for your time. I believe that there is an evaluation, which I'm hoping some of you are nodding, so that's good because that will come from the quality team. So they've asked if you can complete that, and I'll make sure that the slides get sent out to you so that you can have a more detailed look, because I realise it's moving quickly, so it's difficult to always see, and I'll take your comments back as well. So thank you for that, and nice to see you all.
Thanks, Kirsty. That was really helpful. Thank you.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye.
Bye.
Bye.
Bye. Bye.